Hi, my name is Jim Collins. This training program will help you understand how to bill for diagnostic and interventional procedures that deal with the peripheral vascular system. When dealing with the peripheral vascular system, we have to diagnose areas of obstruction and then fix these areas of obstruction when indicated. The peripheral vasculature is illuminated for diagnostic purposes as illustrated on the right here with a sample angiogram. As you can see, the doctor is basically positioning a catheter upstream from an area of suspected obstruction. He then injects a radiopaque substance which helps to illuminate the downstream vasculature. We're looking for areas of obstruction, as is indicated by this arrow, where it looks like there's kind of an hourglass type of an obstruction. Now this obstruction is going to occlude the flow of blood that's moving downstream, and in a lot of times the patient's going to be symptomatic, or they're going to have organ failure if the artery that's occluded happens to supply an organ, as would be the case with renal arterial disease. In order to do these studies, the doctor has to manipulate the catheter, inject contrast, and visualize the contrast flowing through the downstream vasculature. When we code for these procedures, there's truly three different sets of rules that we have to be cognizant of. The first set of rules is for procedures that are purely diagnostic in nature. The second set of rules deals with interventional procedures, whether or not they include a diagnostic piece. The third set of rules has to deal with a specific set of vessels called the carotid and vertebral vessels, or those vessels that supply blood to our brain. It's just a slightly different set of rules for each of these three different scenarios. The first set of rules that applies to diagnostic-only procedures requires us to code for both the catheter placement and for the diagnostic study that's performed. The second set of rules, we're going to code for any diagnostic procedures that are performed and clearly documented. We're going to code for the interventional procedure, and then if we see that there's multiple access sites involved, which is not typically the case, but in those limited cases where there are multiple access sites, we'll be able to code for the catheter placement in addition to the intervention and potentially the diagnostic study that's performed. Carotid and vertebral interventions is the third pathway, and this is just a very unique set of rules in which we code for the intervention, but we're precluded from billing for the catheter placement or the diagnostic study of the vessel that's being intervened upon. I'll explain each of these in a stepwise fashion so you can kind of build on this concept. The first set of codes and rules that I want to focus in on is the catheter placement, which again is going to apply to all purely diagnostic procedures, and in some cases it will also apply to interventional procedures. When coding for the catheter placement with peripheral vascular services, there's two broad sets of codes that we have to choose from. The first is what we would call non-selective catheter placement. The second is called selective catheter placement. Non-selective catheter placement, it basically includes positioning a catheter inside of the patient's arterial system and then moving that catheter either towards or actually into the aorta. Either of these scenarios would still be considered non-selective. The most common non-selective codes that we'll use are 36140 and 36200, which I've got illustrated on the bottom of this slide. You can see 36140 on the left-hand side, where the doctor is basically positioning a catheter or a sheath into an extremity artery. Once the tip of that sheath or catheter enters the extremity artery, the doctor will inject contrast. That contrast then flows downstream and allows us to get a diagnostic study performed of the downstream vasculature, and this is coded with 36140. The second illustration here on the right-hand side is an illustration of what a 36200 would look like. And you can see that after the doctor obtained vascular access, the catheter was moved towards the aorta, and then it actually went into the aorta. So the code itself is going to change. The moment the doctor obtains vascular access, the code that's supported at that point in time is 36140. As he moves the catheter towards the aorta, it stays at code 36140 until he crosses that invisible line that separates the right lower extremity from the aorta. As soon as the tip of the catheter crosses that line, the code changes from 36140 to 36200. The 36140 is no longer separately reportable, even if the doctor were to do a sheath shot and then move the catheter into the aorta. The fact that the catheter ultimately made it into the aorta makes it so that's the only code that we're going to be reporting. Now, the full definition of these codes I've got on the next slide here, and you can see 36200, its official definition is just introduction of catheter, aorta. 36140 is defined as introduction of a needle or intracatheter into an extremity artery. So these are very clean-cut, well-defined services, and the illustrations that I showed you on the last page are truly pictures of what the doctor is dealing with. The other non-selective codes that are available are extremely rare in comparison. The one that we might use occasionally in some groups is 36145, which says that we're basically doing an AV shunt catheterization for diagnostic purposes. The other ones that are listed on here are extremely rare. For a number of different clinical reasons, doctors just do not perform these services very frequently. For example, the last one on this slide says introduction of the catheter into the aorta via a translumbar approach, which basically means that we're going in through the patient's back, which is just, it's not a procedure that's performed very commonly in practice, and you could go your entire coding career and never report this 36160 accurately. So kind of focus in on the two codes that are the most common, and those again are the 36140 and the 36200. Now, in order for us to graduate from a non-selective cath placement up to a higher paying selective catheter placement, one of two things has to happen. The first thing that can happen is we move from our access site downstream or with the flow of blood, and we go through a bifurcation in the extremity pathway. And a bifurcation is just a fancy word to say that there's a fork in the road. So as the catheter moves away from our access site and starts moving downstream, which a lot of doctors are going to call that an antegrade approach, meaning we're going with the flow of blood down towards the patient's feet, eventually we're going to get to a point in the road where the road splits. And the doctor basically has to manipulate the catheter to make sure that it goes down the left side of the fork or the right side of the fork. As soon as the tip of the catheter makes it through that fork in the road, think of it that the doctor has basically selected to go down that particular pathway. And at that point, our code changes from a non-selective code up to a selective code. The other way that we can obtain selective catheterization is illustrated on the right side here, where you can see that the catheter basically enters the extremity artery, goes up into the aorta, over what the doctors a lot of times will call the horn, because it looks somewhat like a horn there, which is the aortoiliac bifurcation, or where the aorta bifurcates into the right leg and the left leg. And the catheter then moves over into the opposite leg, or the contralateral leg. As soon as the tip of the catheter leaves the aorta, our code changes from a non-selective 36200 in this case up to a selective catheter placement. Now, when we're looking at coding for selective catheter placements, the next concept to understand is that there's different levels of selectivity. So as soon as we achieve selective cath placement via either of those two approaches I just illustrated, we call that a first order selective cath placement, because that's the point at which the catheter placement is first considered to be selective. Now, in this diagram, you can see that there's three different levels of selectivity illustrated. The first one shows as soon as the tip of the catheter leaves the aorta and goes into the left lower extremity, we have first order selective catheterization. In this diagram, imagine that the doctor continued moving the catheter downstream in that left lower extremity and went through the next bifurcation that's encountered. As he approaches that bifurcation, again, we have to choose. Do I want to go to the left-hand side of the fork in the road, or do I want to go to the right-hand side of the fork in the road? Manipulating that catheter to make sure it goes to the left or the right increases our level of selectivity up to what we call second-order selective cath placement. And if we were to continue moving down the leg, we're going to eventually come to another fork in the road. When the tip of the catheter goes through that fork in the road, it's considered a third-order selective catheter placement. Now, when we look at the codes that are available to report selective catheter placements with, you'll see that there's truly a six-pack of different service codes that we're going to have to consider first. The three at the top here, 36215, 16, and 17, represent the codes that we'll use for first, second, and third order catheterization in vascular families that originate off of the aorta above the diaphragm. The 36245, 46, and 47 codes are the same thing, first, second, and third order catheter placements that happen to originate in vascular families below the diaphragm. So for coding purposes, think of the renal arteries and all of the arteries in the lower extremities as being below the diaphragm. The carotid arteries, the vertebral arteries, the subclavian arteries are the main arteries that we deal with in the cardiology world that are above the diaphragm. So those would be the 36215, 36216, 36217. Now, when you look at the code definition for the codes that end in a 7, the 36217 and the 36247, you'll see that their definitions actually say third order or more selective. So of course we could get to a catheter position that's fourth, fifth, or sixth order selective in one of these lower extremities. And this diagram helps to illustrate the example of a sixth order selective catheter placement, where the tip of the catheter is basically being positioned, down in the trifurcation area of the patient's leg. As we move from the aorta into the left lower extremity, we graduate to a first order cath placement. As we go through the bifurcation that separates the internal iliac and the external iliac, that's second order. As we go into the superficial femoral, that's a third order cath placement. As we go past the genicular arteries, that's the fourth order. As we go down into the popliteal, or from the popliteal down into the tibio-perineal area, that graduates us up to fifth. Each time we go through a fork in the road, our level of selectivity increases. Now the code that we're going to bill for this diagram is still 36247, and that again is because it's defined as third order or more selective. So in this case, the doctor could have stopped at the superficial femoral artery, the point at which we first become third order selective, and he'd still be able to bill for the same code, 36247. As we look at the compensation that's originated in the way that we code for these services, when we use code 36247, it compensates us for everything involved in the procedure as far as the catheter placement goes, from our access site all the way to the tip of the catheter in that third order or higher position. Now, in some cases, the doctors are going to go off of that beaten pathway. In other cases, they're just going to do multiple diagnostic studies along that same vascular pathway. And if we stop 3 or 4 times on our way down to the trifurcation area in the patient's lower extremity, we're still only able to bill that one code. So everything along the beaten pathway, from our access site down into the trifurcation area, into the anterior tibial, posterior tibial, perineal arteries, is compensated by that 36247. In this next diagram here, however, you'll see that there was 2 side trips that were added on. So after the tip of the catheter reached its ultimate position, the catheter was withdrawn and then advanced into in this case it was advanced into the left perineal artery, and then it was advanced into the left anterior tibial artery. Now, these 2 side trips are not compensated by code 36247. Only the catheter manipulation from our access site to that ultimate position is compensated by 36247. These 2 little side trips will actually generate additional reimbursement, almost $50 worth of reimbursement each, as long as we code for them accurately. Now, the codes that we're going to use for these 2 additional side trips, there's 2 different codes to choose from. One is applicable to side trips that take place above the diaphragm. The second is for side trips that take place below the diaphragm. 36218 is for above the diaphragm, and 36248 is for below the diaphragm. As we look at the definitions of these codes, you can see that they specifically say additional second order, third order, and beyond catheter placement within any of those vessels that are considered above or below the diaphragm. So 36248 would be the code that we'll use for each of these side trips in this particular diagnostic case. So we'd use codes 36247 to compensate us for the most distal place that the catheter reached, and then we get to bill for code 36248 two times in addition to the 36247. And this is one of those services that frequently gets lost when coding because either the doctors don't clearly document that I positioned my catheter in the anterior tibial and then I withdrew it and I advanced it into the posterior tibial. And they really need to clarify that in their documentation. So the doctors who understand the coding rules and understand how important it is to document those additional side trips, of course, are going to be more compliant when they bill for their services, and they get paid for a higher percentage of the work that they're doing as well. So it's certainly a message that you would want to make sure to share with your physicians if they're not in the habit of doing that already. In some cases, we'll have multiple access sites involved instead of one access site. Now, the concepts that apply to multiple access sites is really just a duplication of the concepts that I just explained, in that from each access site, we have to look and see where did the tip of the catheter go from access site A, and where did the tip of the catheter go from access site B, and code each of those separate access sites out separately, as though they were two completely separate operations, basically. In this diagram, you can see an example of a first-order selective catheter placement, and this is from the green access site. And the catheter basically goes up into the aorta, and then it goes over the horn and into the contralateral common iliac artery. And as soon as we leave that aorta and enter the contralateral common iliac artery, we graduate up to a first-order selective cath placement. Since this is below the diaphragm, the code that we'll use for a first-order cath placement is 36245. The red access site, you can see the doctor just advanced the catheter towards the aorta. However, he never made it actually into the aorta from that access site. So the code that we'll use for that is 36140. This concept of reporting multiple access sites is going to come in handy, especially when we're dealing with diagnostic procedures and interventional procedures done during the same operative session, when a diagnostic study is done from one access site and the intervention is done from a second access site. Now, when we bill for the diagnostic imaging that goes along with the peripheral vascular studies, we have to kind of understand that the codes available are just broken up by different anatomic areas. The first anatomic area that we need to kind of cover is in a lot of regards one of the most complex, just because there's some overlap in commonly performed diagnostic studies. The aorta is broken up into different segments for coding purposes, and a lot of times doctors refer to these segments in a similar way that the code structure refers to them, but of course in some cases doctors use terminology that's a little bit different than what we see in the code structure. So this diagram just illustrates the different segments of the aorta that we have to understand for coding purposes. So as the aorta originates, there's the left ventricle squeezes blood out of the heart. There's an aortic valve that separates the aorta from the left ventricle. As soon as we're on the other side of that aortic valve, we're in what's called the ascending aorta, where a lot of doctors will refer to this as the aortic root, because this is where the aorta originates. So kind of like a plant has a root structure, this is the root of the aorta. So whether the doctor calls it the aortic root or the ascending aorta, he's referring to the anatomic area that's labeled A on this diagram. Once we get up into that arch-shaped part of it, they call that the aortic arch. Once the aorta starts traveling down the body, we call that either the descending aorta, whereas a lot of doctors will also refer to that as the thoracic aorta. The diaphragm is there where the color codes change from black to white. That's basically where the diaphragm is going to be in the patient's body. And once we cross through the diaphragm, it stops being called the thoracic or the descending aorta, and we start calling it the abdominal aorta. The abdominal aorta, of course, bifurcates, and it bifurcates into the lower extremities. The first vessel that originates on the far side, or the distal end of that bifurcation, is the right and the left common iliacs. The common iliacs bifurcate into the internal and external iliacs, and then we get down into the superficial femoral and the profundifemoral in that next bifurcation. But basically, focusing in just on the aorta here, it's important to understand that there's two, three, four different segments of the aorta that a lot of doctors are going to be doing diagnostic studies in, and we want to make sure to just kind of label those out on a diagram like this, so that when you're reading through operative reports, you can piece together the codes that go along with each of these different studies. The codes themselves I have set up on this one slide, and you can see there's basically 5 different codes that are available. The two that are ranked number 3 and 4 here, the 75625 and the 75630, are by far the most common aortic imaging codes, or aortography codes. The 75625 says we're doing a full diagnostic study of the abdominal aorta, and code 75630 basically says we're doing a bigger study that includes both the abdominal aorta and a bilateral iliofemoral runoff. And all that means, bilateral means we're looking in both legs, and iliofemoral just means that we're looking at the iliac arteries and we're looking at the femoral arteries. So we have to include both the iliacs and the femorals in the doctor's diagnostic report in order to graduate from a 75625 up to a 75630. The 75650, the last code that's listed on here, is a pretty common service, and this is basically just looking at the arch of the aorta and the place where those great vessels originate. The 75600, which is the first one that's listed up here, you're never going to report. That basically says that we're doing a thoracic study without using serialography, and serialography is just that fluoroscopic imaging that I mentioned earlier, where the doctors are injecting a contrast and then they watch that contrast flow down the patient's vasculature. That's what everybody's doing now in the United States. So the 75600 code, I don't think you're going to report that any longer. If you ever have before, if it's on your billing sheet, it's probably safe to just eliminate it. You could, of course, check with your physicians or a lab technician to make sure that you don't have that old equipment in place. 75605 is doing a thoracic study, but you're using serialography with that, and that happens occasionally, but much more commonly you'll see that as far as the aortography codes, the two that I kind of drew your attention to are going to be the ones that dominate the overwhelming majority of diagnostic studies, and those being, again, the 75625 and the 75630. Illustrations of what these two different studies look like are positioned right here, and what you can see is that the 75625, there's on the left hand side here we have a catheter access in the right lower extremity. The catheter is just advanced to a position where it's just above where the renal arteries originate, and for the sake of coding 75625, it truly doesn't matter if the catheter is just above the renal arteries or just below the renal arteries or right at the renal arteries. Since we're not specifically coding for the renal angiogram, the aortography, the abdominal aortography, could be anywhere that we call in the perirenal position, meaning anywhere in the ballpark of the renal arteries is basically where the abdominal aorta originates. So as long as the tip of the catheter is somewhere in that general area, we could still bill that 75625. The orange here just illustrates the field of view that the doctor is looking at and watching the contrast, and then, of course, creating a report that's telling us what that anatomic area looks like. The 75630, you can see the catheter is positioned in exactly the same position, in this case just barely above the renal arteries. The contrast is injected, it flows down the abdominal aorta, and then the doctor is following it. The field of view is moving and actually looking down into the iliac arteries, the common femoral artery. It goes into the superficial femoral and off into the profundifemoral in both legs. That's what meets the definition of code 75630, meaning abdominal plus bilateral iliofemoral runoff. Now, if the doctor had only looked at what the iliac arteries look like, as is illustrated on the left diagram here, that of course doesn't meet the definition of abdominal plus bilateral iliofemoral, so we're stuck using that 75625 code for the first diagram on the left here. Next, we'll look at the carotid arteries. From a coding perspective, there's 3 separate sets of carotid arteries. The first is referred to as external, the second cerebral, and the third is cervical. Now, the cervical carotid arteries are the ones that are in the neck area. The cerebral arteries are those that flow up into the brain, and the external carotids are carotid arteries that branch around the outside of the brain. External carotid studies are extremely rare, and these are ones that you may never bill for accurately. just because the definition itself includes the word selective. Now, while a lot of doctors will will visualize and comment on what the external carotid arteries look like, that little word selective in their definition is going to preclude us from billing for those probably 99 or 100% of the time, simply because most of the time cardiologists are not going to advance a catheter up into the external carotid arteries selectively. So you can kind of scratch those ones off of the short list of services that you're going to bill quite frequently. The cerebral carotid arteries are not that commonly performed either. These require the doctor to document what that full cerebral distribution looks like. A lot of times the physicians will comment briefly on what the cerebral arteries look like. However, they don't feel comfortable reporting that as a full diagnostic study. The cervical carotid arteries, however, are the most common, and these ones, even though the code definitions say cervical, a lot of times you'll see these referred to as the common carotid arteries. And basically, from an anatomic perspective, the common carotid arteries branch up from the aortic arch area, and then there's a thing that we call the bulb, and the bulb is just like this little outcropping of the artery, which then bifurcates into the internal and external carotid arteries. In most cases, the doctors will position their catheter in the common carotid artery, inject contrast, and then their diagnostic report will illustrate both what the common carotid, the bulb, the internal, and the external carotid arteries look like. We would only want to bill the cerebral arteries if the doctor truly described what the cerebral distribution looks like. And as I just mentioned, those external carotid arteries, pretty much all of the time, they're not going to be able to separately bill those because the catheter is not being advanced that far into the brain. The next set of arteries that we'll look at are the renal arteries, and these codes have been substantially overhauled in the last couple of years. The two codes that I have listed on the top here, the 36251 and the 36252, are going to be what we bill probably 95+% of the time. These illustrate that we're doing a first order selective catheterization and diagnostic imaging of the renal artery. So unlike the carotid study codes, where we're going to be billing for both the catheter placement and the diagnostic imaging, these renal study codes are all in one. So you can already see how we've got multiple sets of rules that we have to understand and apply. There's really no logic behind allowing us to bill for catheter placement with a lower extremity study but not with the renal study. It's just one of the many complications that we have to deal with. It's a very imperfect coding structure. However, by understanding these hard and fast rules, we can certainly accurately report services, get full compensation for the work that's being performed, but don't always try to find logic in the way that we report these. There's just an absence of logic when we're dealing with a lot of these things. So 36251 says we're doing a unilateral first-order selective study of a renal artery. 36252 says we're doing a bilateral first-order study. And as you'll see in the definitions of these codes, they tell us that the work of visualizing accessory renal arteries is included in these codes. So an accessory renal artery just means that instead of having one renal artery on the right or the left side, this patient has multiple renal arteries. So we have a major renal artery that's coming off the aorta, and then there's a second one that's either just above or just below it. So these codes include the work of catheterizing and imaging any accessory renal arteries that happen to be involved as well. The second set of codes on the bottom here, the 36253 and 36254, are only used if the doctor goes into a second order or higher catheter position within the renal arteries. This is not that common. However, these codes were created to allow physicians to get a little extra compensation when they make the extra effort of going into a second or a third order catheter position in those renal arteries. It's just, again, keep in mind that we want to focus on the most common services. It's important to understand that these other ones happen occasionally, but as far as the codes I would expect to be seen reported with any frequency, it would be really limited to the first two that are listed here, the first order catheter placements. The only time that we're going to be able to bill for the 36254 code is if we go into a second order position in both the right and the left renal arteries. And the descriptors and the guidance that they give us in the CPT book really enforce this. Specifically, they tell us that we should not report 36254 in conjunction with 36252. That's the first thing that they tell us. So the 36254 says we're doing a bilateral second order or higher, and the 36252 says we're doing a bilateral first order selective cath plate. So it's either going to be one or the other. And the only time that we'll be able to bill for the 36254 is really if we go into a second order on both the right and the left side of the patient's body. The second instruction that CPT gives us is to not report 36253 in conjunction with 36251 when performed for the same kidney. And of course, that just means if we're only looking on the right side or on the left side, it's either going to be a first order or a second order cath placement. We're not going to bill them both on the same side of the body. We could, of course, bill 36253 on the right and 36251 on the left, however. But if they're both in the same renal artery, we would only bill one or the other. The other specific vessels that are recognized in the code structure have to deal with things that the vessels that aren't carotid or renal arteries, and the ones that are the most common I've got listed at the top here, which are your 75710 and 75716. The 75710 just says that we're doing a unilateral extremity study, and the 75716 says we're doing a bilateral extremity study. What you'll notice is that these codes do not differentiate between selective or non-selective, and they don't differentiate between upper extremity or lower extremity. So it's really obscure that we break down the renal arteries into such fine detail that we have to figure out what level of selectivity we're at, and the codes are all bundled up. And the same happens with the carotid arteries, whether we're looking at the cervical portion or the cerebral portion, and etc. But when we're dealing with the extremity studies, it doesn't matter if we're above or below the diaphragm. It doesn't matter if we're selective or non-selective. The 75710 and 75716 just kind of encompass all of that work. The other codes that are on here, the brachial, the vertebral, the visceral, the pelvic studies, the code definitions pretty much describe what the service is that we're billing for. The main thing that I recommend that you focus in on are which of these definitions have the word selective inside of them, because in order to bill for a diagnostic study that has the word selective in its definition, the catheter has to be selectively engaged in that vessel. So when we're looking at the visceral vessels, it has to be selective. When we're looking at the pelvic vessels, which is going to be your internal iliac most commonly, the doctor has to position the catheter inside of the internal iliac arteries in order to bill the 75736 code. And it specifically says we're either selective or super selective, which apparently just means second, third, or higher order, which is just occasionally they'll go selectively into the internal iliacs, but most of the time the catheter is positioned in the common iliac artery, and then the contrast is just allowed to flow down through that bifurcation where the internal iliac and the external iliac kind of branch off or bifurcate. So a lot of times we're not going to bill that code, even though the doctor might comment on what those internal iliac arteries look like. The last diagnostic imaging code that I'll reference is the 75774, and this is the most commonly missed code in my perception in peripheral vascular billing, and I think one of the reasons is just because it's at the very end of this section of the CPT book. This should be one of the most commonly reported codes, and it generates a nice amount of reimbursement when we bill for it accurately. Code 75774 says that we're doing an additional diagnostic study of an anatomic area that we've already performed a diagnostic study in. So it's an add-on code. We can only bill 75774 if we have a base code reported. The base code is going to say, okay, this is where I did my initial study of this left lower extremity. And then 75774 says, I moved my catheter to a different selective position, a different position than where I did my basic study from, and I did a second study or a third study or a fourth study. The 75774 code just gets added on each time we move the catheter to a different position and then do another diagnostic study from that area. The diagram that I've got up here kind of illustrates, it's not that uncommon of a procedure, but it kind of illustrates how these codes all kind of play together. So what you can see here is that we have an access site in the right lower extremity. The doctor obtains access and then advances the catheter up to above the renal arteries. That's the first position that the catheter is moved to. From that position, contrast is injected. The diagnostic study that's performed is kind of outlined in this red color here, and that, of course, just looks at the abdominal aorta. After that study is performed, the doctor moves the catheter down to that aortoiliac bifurcation and does a second study. This second study I've got illustrated in orange, and this orange is, of course, just to illustrate the anatomic area that's visualized from this second diagnostic study. And that's just looking at the right and the left lower extremities, so that's a bilateral lower extremity study. After that study is performed, the doctor identifies that there's an abnormal filling defect or potentially an area of obstruction over in the left leg. So he moves the catheter selectively down into the superficial femoral artery and does another diagnostic study, which is just illustrated in green here. That study illustrates that there's more extensive disease down in that trifurcation area. So the doctor moves the catheter all the way down to the distal part of the popliteal arteries and injects contrast that just flows into that trifurcation area. So from a catheter coding perspective, we'll tackle that first. That's that first set of codes. Since we ultimately made our way to a third order or more selective position, and in this case it's what, a sixth order position, we get to use code 36247 for the catheter placement. Now, regardless of the fact that we stopped at multiple places to do diagnostic studies, that 36247 code compensates us for all of the catheter work in this particular procedure. The diagnostic imaging, however, are all separate studies that we're going to report, so we'll first bill code 75625 for the abdominal aortic study. Then from the aortoiliac bifurcation, where one injection is done that kind of goes down both legs, that's going to be our bilateral lower extremity study, or code 75716. Then the doctor moves the catheter down into the left superficial femoral artery. So we've already done our basic study of that leg. Now we're moving the catheter to a different selective position and doing another diagnostic study. That's exactly where code 75774 comes in play. And then in this illustration, the doctor went further down into the popliteals and did another additional study. So we get to bill code 75774 a second time. We can only bill all these codes if the doctor's report clearly illustrates, I went here, and then I went here, and then I went here. So without the documentation, we of course would not want to bill these codes. However, when physicians clearly document what they do and explain it kind of like a storybook of a children's book of where did the tip of my catheter go on vacation this week, we can really piece together all of these different services and submit a claim that's absolutely accurate and captures all the reimbursement that the doctor earned. Another diagnostic component to some peripheral vascular procedures is what we call IVUS, or intravascular ultrasound. This is just a different way to identify what's causing these areas of obstruction in the peripheral vessels. It helps to illustrate, in these areas that have this hourglass type of obstruction, we want to identify, what is the material that's making up that obstruction. Is it malleable, which it would just be like a buildup of cholesterol and fatty deposits, if you will. These are smushy areas of obstruction. We can inflate a balloon inside of those and kind of smush them open, and sometimes that's all that's necessary. Whereas IVUS might illustrate that this obstruction is really not as severe as the angiography might illustrate, because the angiography is really just giving us a silhouette of what the vessel looks like. So we're looking at it from one particular angle, whereas if we look at it from another angle, it might not be that severe of an obstruction. IVUS just helps to illustrate that, and IVUS just means that we're putting an ultrasonic transducer on the tip of the catheter and advancing into the area of obstruction and kind of doing what you might think of as a kind of like an echocardiogram, but we're doing it from inside of a peripheral vessel. And that just helps to illustrate that. Now there's 4 different codes that we have to kind of keep in mind when we're billing for peripheral vascular IVUS. They're each illustrated here. The 37250 and the 75945. We bill both of these codes for the initial vessel that we perform IVUS in. The 37251 and 75946 codes, we're going to bill for each additional vessel that we perform IVUS in. So in any given case, you might see IVUS being performed in one vessel. Occasionally, doctors will do IVUS in multiple vessels, and in those cases, you would bill all 4 of these codes. If the doctor looked at 2 separate vessels using IVUS in both, we get to bill all 4 of these codes on there. When we kind of shift and start looking at the interventional procedures, this is where we have to kind of step back to that original concept that there's three different pathways to go down. So the first pathway I fully explained, which is describing how to bill for a purely diagnostic procedure. We're always going to want to identify what the catheter position is. Typically, we're able to bill for the cath position. The only exception to that would be the renal studies, of course. And then we bill for the diagnostic component as well. When we see an intervention being performed in the report, we have to kind of twist it around a little bit, because the introductions that came with the current set of interventional codes for lower extremity procedures here basically tell us that lower extremity endovascular revascularization codes include catheterization. So we're not allowed to bill for catheter placement if we're doing a lower extremity intervention. They also tell us that the catheterization codes are not reported for diagnostic lower extremity angiography when performed through the same access site as therapy, and that catheterization for diagnostic lower extremity angiogram may be reported separately if a different arterial puncture site is necessary. So this goes back to what I said a while ago, which is if multiple access sites are used and one access site is used just to perform the diagnostic procedure, the second access site is used to perform the interventional procedure, we get to code those two access sites out as though they're two separate operative sessions. In most cases, however, the doctors are going to be doing the diagnostic piece and the interventional piece just from one access site. So this sample case number 1 just illustrates obtaining vascular access in the right lower extremity, advancing the catheter over to the superficial femoral artery, and then when we do the diagnostic piece, we identify that there's a need to do an intervention, and the intervention is done during the same case. In this scenario, even though the doctor obtained third-order catheter placement when doing the diagnostic piece of the work, the fact that he or she ultimately went on and did an intervention in that superficial femoral artery precludes us from reporting that 36247. The second case study that I've got here shows an intervention being done in a different manner. So here you can see that the first access site is up in the arm area, and this is the red catheter, and you can see that the catheter is advanced all the way down into that common femoral artery, which, if you just kind of keep in mind the concepts that we mentioned earlier, we first obtain access in an extremity artery. In this case, it was an upper extremity instead of lower extremity. The catheter is moved into the aorta, all the way through the aorta, down into the left common iliac, and then through that bifurcation that separates the internal and external iliac. And then, of course, on the far end of the external iliac, that vessel crosses the femur in the leg, and that turns into the common femoral artery. So even though there's not a bifurcation there, we're ultimately positioning the catheter into the common femoral artery, which, as soon as we leave the aorta, we're at first order selective. As soon as we go through that bifurcation that separates the internal and external iliac, we're at second order selective. The fact that we went to the most distal point of that vessel, the point at which the doctors are going to start referring to it as the common femoral, it doesn't increase our level of selectivity. So it's a second order catheter placement that we have from this red access site, and we get to bill for that with code 36246. Once that diagnostic study is done, the doctor identifies a need to do an intervention in that left lower extremity. And rather than doing it through the same access site, the doctor obtains a second access site, which is illustrated in green here. And you can see that the catheter is just moved down into the superficial femoral artery for the actual intervention. In this particular scenario, we're going to be billing for the interventional procedure, we're going to be billing for the diagnostic procedure, and we get to bill for the catheter placement that's illustrated in red here. So the catheter placement that goes along with the green access site, the one that's done strictly for interventional purposes, we're not going to report that, even though in looking at the diagram you could say, well, that's a first order cath placement because the doctor went in through an extremity access and then down through a bifurcation. It is a first order selective catheter position, but it's not reportable because that selective catheter positioning is included in the work that we're going to get compensated for when we bill for the actual interventional procedure. Diagnostic angiography is going to be separately billable whenever it's performed, however, it has to truly be diagnostic in nature. Now, the two different points that I'll make about this come straight from the CPT book. The first is that if no prior catheter-based study is available for full diagnostic review, and that the decision to go ahead and do an intervention is made based on the angiography done at the time of the intervention. In those cases, we'll be able to bill for the diagnostic imaging codes in addition to the interventional procedures. Another guideline that's available in the CPT book basically says that if a prior study is available, but the medical record clearly illustrates that the patient's condition with respect to the indication for the procedure has either changed, that there's inadequate visualization of the anatomy or pathology, or that a clinical change during the procedure requires a new evaluation outside of the target area. In those cases, we can bill for a diagnostic procedure. So in most cases, we'll be able to bill for these diagnostic studies if a doctor does a diagnostic procedure and then moves on to doing an intervention during the same case. We would lose the ability to bill for the catheter placement, but we'd still bill for the diagnostic imaging. When we move on to the interventional codes themselves, what you'll see is that there's three different main categories of intervention that we're going to have to consider. The first is angioplasty, which is just positioning a balloon inside the area of obstruction, inflating the balloon, and that smushes that malleable substance, the fatty deposits, the cholesterol deposits, if you will. It kind of smushes them to the outside of the wall. It also stretches the vessel considerably, making a bigger lumen for blood to flow through. That's what we call angioplasty. Atherectomy involves actually removing atherosclerotic plaque from the area of obstruction. And then finally we have stent placement, which is just expanding a small metal mesh tube inside the area of obstruction, and that allows us to have kind of like a scaffolding in place after we withdraw the catheter and the patient goes home. When coding for interventional purposes, the first area that I want to focus on is the lower extremities, just because these codes are probably the most complex to understand and apply in practice. There's seven different vessels that are recognized in each of the lower extremities for interventional coding purposes. There's several more vessels than 7 in the actual leg. However, from a coding perspective, they've bundled these vessels into each other, which has the end result of us being able to report fewer codes. And that's kind of the evolution of the code structures, is that they bundle things together in an effort to create administrative simplification for us. In reality, it just kind of makes the coding for these procedures a little less logical and a little bit more complex. The diagram that I have here just gives you a color-coded illustration of what the 7 vessels are that are recognized, and I've broken these up into what I like to think of as a 3-1-3 structure. As we first make our way down the leg, there's 3 separate vessels recognized that are called iliac vessels. There's the common iliac vessel, which is labeled in green, the internal iliac, which is labeled in red, and then the yellow vessel here is the external iliac / common femoral artery. Each of those 3 vessels is considered to be a separate vessel for interventional coding purposes, and in each one of those 3 vessels we could report one intervention. As we make our way down from the external iliac into the common femoral, profundifemoral, superficial femoral, you can see that there's just, and even the popliteal vessel, that's all considered to be one vessel for coding purposes when we're reporting an intervention. So everything in this turquoise area here, all the way from the common femoral down to the trifurcation, which is at the distal point of the popliteal vessel, all that is considered one vessel. So if we did 3 different interventions at 3 different points in this turquoise area, we're only allowed to bill for one intervention in that entire segment of vessels. Down in the trifurcation area, they've recognized 3 separate vessels, and you can see that the perineal, the anterior tibial, and the posterior tibial are each colored a different color. Now, the one segment of vessel that is not colored here is what we would like to think of as the common trunk of the tibioperineal distribution. This particular vessel is intervened upon quite frequently. However, from a coding perspective, we have to treat that intervention as though it was done in one of the distal branches. So we're going to report that as being done in either the posterior tibial or the perineal vessel. And if there's an intervention done in one of those distal vessels, then they tell us to treat that common trunk as though it was actually just a segment of one of those distal vessels. So we're only able to report up to 3 interventions in that trifurcation area. So as we work our way down the leg, there's 3 potential interventions in the iliac system. there's only one potential intervention that we could report in the entire femoral popliteal distribution. And then when we get down into the trifurcation area, we could report up to 3 interventions. So this 3-1-3 concept, I know it sounds a little bit corny, but as we start looking at the codes that apply, you'll see that having this 3-1-3 point of reference really helps to put these codes together and make sure that we don't leave any revenue on the table. The first set of interventions that I'll talk about are the angioplasty. This is the least intensive of the interventions. As we look at the iliac angioplasty codes, you'll see that there's 2 separate codes. The first one here, the 37220, says that this is the initial iliac angioplasty that's being performed in each leg. When we build this initial iliac angioplasty code, the 37220, we're getting paid for both the angioplasty, the placement of the catheter into that segment of 3 vessels, and also any imaging that's necessary to perform the intervention and to confirm that the intervention was successful. And doctors, of course, will refer to that as a completion angiogram. They basically will angioplasty the segment of vessel that's occluded, that has the blockage in it, and then they'll inject a little bit more contrast to kind of see what the result of that effort is. That's all included in the work of the 37220. The 37222 says I'm doing an initial iliac angioplasty in the same leg that I just built a 37220 in. So the 37220 is kind of like a package code. It's like a cover charge to get in and do the first intervention in that segment of leg. And then the 37220 says, after I've already billed for and gotten compensated for this big cover charge service, I'm also doing another angioplasty in another recognized iliac vessel. So one of the ways to look at this would be that the most complex angioplasty we could do in the iliac vessels would be a procedure that includes angioplasty of the common iliac, the internal iliac, and the external iliac. And that would be reported with code 37220 would be reported 1 time, and code 37222 would be reported 2 times. As we make our way down the leg into that femoral and popliteal area, which includes the common femoral, the superficial femoral, the popliteal, there's only one recognized vessel for angioplasty purposes, so they only give us one code for that, this 37224. Even if we did 6 different angioplasties in that segment of vessels, we only bill this code 1 time. And then once we get down into the trifurcation, there's 3 recognized vessels. So we go back to the same coding structure as we had with the iliac vessels, in that there's 1 vessel code for the initial intervention, the initial angioplasty that's done. That's 37228. And then there's an add-on 37232. So the most complex angioplasty procedure we could do there would be reported with 37228 once and 37232 2 times. When we move on to atherectomy procedures, a monkey wrench is thrown in by the fact that physicians truly aren't doing that many atherectomies in the iliac vessels or anywhere above the iliac vessels, specifically in the aorta and the renal arteries. Just atherectomy in those vessels is extremely rare. I've had several physicians tell me that there's not even catheters that are large enough to do effective atherectomy in those areas. And I think because the fact that very few physicians traditionally would report atherectomy in the iliac vessels, the aorta, or the renal arteries, the codes that go along with these have been downgraded to a Category 3 status. So when we look at the code that's available, this 0238T, which says that we're doing atherectomy in an iliac vessel, you're going to find that in the back of the CPT book in the Category 3 codes. It's an extremely rare procedure. This might be another one of those ones that you just kind of forget about. But in the rare case that you do it, you want to keep in mind that this particular code, this 0238T code, does not include the catheter placement that's necessary to do the procedure, so we could bill for the catheter placement separately. And also they say that this is separate from the angioplasty or stent placement. So if we happen to do atherectomy and then stent a iliac vessel, we're able to bill for both this temporary status Category 3 code as well as the stent code that goes along with it. And we'll get to those stent codes in just a minute. It's a very rare procedure, so don't be distracted by that one too much. When we get down into that fem-pop distribution, atherectomy in this segment of vessels is extremely common. And in a lot of cases, we'll see pretty extensive atherectomy procedures being performed all along the course of this distribution. Since this is all considered to be one vessel for coding purposes, they only give us one code for it. So whether we do one atherectomy or two or three atherectomies in this segment of vessels, we're only able to report this FEMPOP atherectomy code, the 37225, just one time. Once we get down into the trifurcation area, we go back to that same concept that there's an initial vessel that's receiving atherectomy, and then there's each additional vessel that's receiving atherectomy, being the initial vessel code, the 37229, and then each additional vessel being the 37233 codes. Now, each of these atherectomy codes, whether we're dealing with the FEMPOP distribution or the tibio-perineal area, the definitions of these codes says that we're doing atherectomy of this particular vessel, and it includes angioplasty when performed. So whether we do angioplasty first and then atherectomy, or if we do atherectomy and then angioplasty, the work of both the angioplasty and the atherectomy are included in these atherectomy codes. So we're not able to bill for the cath placement, and we're not able to bill for angioplasty that's done. All we would bill for is the applicable atherectomy code. When we go on to the stent placement codes here, you'll see that we go back to this 313 concept, in that in the iliac vessels, there's three potential interventions that we can bill when we're stenting. The initial vessel, the 37221, and then each additional vessel, 37223, are the codes that we'll use for the iliac stent placement. The definitions of these codes, just like the definitions for the atherectomy codes, says that if angioplasty is done, that work is included in the work of the stent placement, so we're not able to bill for it. So as long as we're placing a stent somewhere in an iliac vessel in that particular leg, we're not able to bill for the cath placement or the angioplasty. However, when we get down into that FEMPOP distribution, there's a little bit of an exception for atherectomy procedures. So in the FEMPOP distribution, as I mentioned, there's only one recognized vessel. So no matter what the scenario, we're only going to be able to report one atherectomy or one stent placement in that entire distribution. However, you'll see that there's two codes here, 37226 and then 37227. The reason why there's two codes is that the first one is a plain Jane stent, which may or may not include angioplasty. So ballooning is included in this stent code. The 37227 says, I'm doing stent placement. I may or may not be doing angioplasty, but I'm also doing atherectomy. So kind of think of this 37227 code as a deluxe stent. I'm not just placing a stent. I'm placing a stent, and I'm also doing atherectomy somewhere in that FEMPOP distribution. So only one of these two codes can be billed. We have to say, is it the plain Jane stent, the 37226, or was it a deluxe stent in that the doctor performed both stent placement and atherectomy of that particular segment of vessel? So it's one or the other. When we get down into the trifurcation area, the same concept is applied, except here you'll see there's a total of 4 codes. And the reason this is that the base intervention that we do the stent placement in, we've got two options. So code 37230 says we're doing a plain Jane stent with or without angioplasty. The next code in sequence, the 37231 here, says that I'm doing stent placement and I'm also doing atherectomy. So one of these two codes has to be reported for our initial intervention in that trifurcation area. Each additional vessel interventions could also be a plain Jane stent or a deluxe stent, one that includes stent placement and atherectomy. So they give us two separate codes for each additional vessel stenting in the trifurcation area. 37234 being the plain stent, 37235 being the deluxe, the one that includes the atherectomy. Now, the most extensive stent placement procedure that we could do in the trifurcation area would be one in which we do both stent placement and atherectomy in 3 recognized vessels. And that case would be reported with code 37231 one time, and that's again being like our cover charge service as I described it earlier. And then we bill 37235 2 times, one for each additional of the 3 vessels that are recognized. It's a little bit convoluted, but if you kind of refer back to that 313 concept that I mentioned earlier, you'll see that these codes really line up with that coding methodology. When we do angioplasty above the lower extremities, of course the codes that traditionally have been in place, codes that have been in place for years, are still applicable. We've got specific codes for the aorta, specific codes for the brachiocephalic vessel and the branches that are up there as well, and then specific codes for renal or visceral angioplasty. Now, the codes here, another monkey wrench gets thrown in the system in that these codes still allow us to report the imaging, or what we call the radiological supervision and interpretation, that's necessary to do these angioplasty procedures. So we're not just going to bill for one code. When we're dealing with interventions above the legs, we get to bill for the catheter placement, we get to bill for the intervention that's done, and we get to bill for a radiological supervision and interpretation of the intervention. This is not a diagnostic angiogram. This is an angiogram that's being done strictly to help facilitate the procedure and to make sure that the procedure was successful, that completion angiogram. We get to bill for that when we're doing interventions above the lower extremities. So in the aorta, we bill the interventional code, the 35472, and then we get to bill the SNI code, the supervision and interpretation code, which would be 75962 for the initial angioplasty that takes place in the aorta. And then if we do another angioplasty in the aorta, we bill the same interventional code, the 35472, but we change the SNI code to be the 75964, which basically just says this is an additional vessel that we're doing that radiological supervision and interpretation for. As you can see here, there's just separate codes for the brachiocephalic branch and arteries and then the renal vasculature. They all follow the same structure in that we want to make sure that we're doing a buddy system. We bill an intervention code, and then we bill the radiological supervision and interpretation code. And of course, we get to bill for the cath placement as well because we're not down in the lower extremities. Atherectomy above, well, I guess starting in the iliac vessels and going upward, have all been downgraded to that Category 3 status. These are temporary codes. And what you can see is that these codes 0237T is for the brachiocephalic trunk and branches. The 0236T is for the aorta atherectomy. The 0234T is for the renal, and then the 0235T is for the visceral atherectomy. These are very rare procedures, so don't get distracted by them. You're probably not going to be reporting them much, if at all. Stent placement, when it takes place above the lower extremities, are billed with stent codes and radiological supervision and interpretation codes that have been available and around for a long time, whereas a lot of these lower extremity intervention codes were just introduced back in 2010. The stent placement codes that for procedures that take place above the lower extremities, we're still going to use the 37205 for the intervention, for the stent placement, the 75960 for the radiological supervision and interpretation, and that's for the first vessel that we do a stent placement in. Each additional vessel that we stent, we're going to bill 37206, and then we use the same radiological supervision and interpretation code. So a lot of confusion is created by the fact that the code structure is not in harmony with itself. You know, when we're doing the angioplasties, you know, the SNI code is going to change, whereas the interventional code stays the same. When we're doing stent placement, it's the opposite. It's the stent placement code that changes. The radiological supervision and interpretation code stays the same. So if we were to stent two separate vessels that are above the lower extremities, we're going to bill 37205 and 75960 for the first one, and then we'll bill 37206 and the same 75960. We bill that code a second time for the next intervention. It's a little bit convoluted, but certainly, you know, reducing this information down onto charge tickets or even in your billing system, it kind of, as long as you understand these concepts and apply them in practice, you can arrive at an accurate claim form. Thrombectomy is another service that's performed occasionally in the peripheral vessels. When we're dealing with thrombectomy, it's important to keep in mind that the code structure differentiates primary and secondary thrombectomy. And thrombectomy, of course, since it has the ending ectomy at the end of the word, that means that we're actually removing something from the patient's body. In this case, instead of being atherosclerotic plaque, like we would be removing if we were doing an atherectomy, thrombectomy means we're removing a clot from somewhere inside the patient's peripheral vascular system. The CPT book kind of gives us rough guidelines as far as what is considered to be a primary thrombectomy as opposed to secondary. And what they tell us is that with primary thrombectomy, there's typically going to be pre-treatment planning and post-procedural evaluation that's focused on the thrombectomy procedure itself. Whereas secondary thrombectomy is more specific to removal or retrieval of short segments of thrombus or embolus when performed either before or after another percutaneous intervention. Primary thrombectomy, they say the diagnosis of thrombus has been made prior to the procedure, and that this procedure may precede or follow another percutaneous intervention, whereas with secondary thrombectomy, they tell us that non-primary mechanical snare, basket, or suction technique is typically used, and that this includes intraprocedural pharmacological thrombolytic injections. So secondary thrombectomy is something that's done at the time that we're going in to do a primary intervention. I'm mainly going in to do an intervention during this case. Oh, and by the way, there's a thrombus there, so I'm going to remove it. They call that secondary, whereas primary means I know this patient has this thrombus, and I know I need to go in there to take this thrombus out. That's what they consider to be primary thrombectomy. The codes are slightly different. You'll see with the primary thrombectomy, there's two different codes. The first one is for the initial vessel that we perform this procedure in each vascular family, and that's code 37184. And then we just add one digit on and make it 37185 if we do an additional vessel thrombectomy. With the secondary thrombectomy, there's only one code that's available, and that's 37186. So primary versus secondary, it truly could go either way. Realistically, I think most of the procedures that you're going to be billing are truly going to be secondary thrombectomy, so you should be kind of deferring to that 37186 code more so than the 37184 or 37185. Carotid artery stenting and vertebral stenting is really that third pathway. So I mentioned originally there's three pathways we can go down. There's purely diagnostic procedures, there's interventional procedures that are non-carotid or vertebral, and then this is the third set of codes, or the third set of logical guidelines that we have to follow, which is doing stenting in the carotid or the vertebral arteries. The biggest thing that changes here is that the concepts that apply in the lower extremities don't apply at all when we're dealing with these interventions. The carotid stenting code 37215 is the code that we'll be using for any carotid stent placements that are performed. And this code basically says that the work that we're getting paid for includes the catheterization and any diagnostic studies that are done during the case in this same vessel. So if we do selective catheter placement in the left common carotid artery, and we do a diagnostic study of that vessel, and then we stent that vessel, the fact that we stented that vessel means the only code we're going to bill is this 37215. We lose the ability to bill for both the catheterization and the diagnostic imaging that's performed in that. The only time we're going to be billing for catheterization or diagnostic studies is if we're doing studies in other specified vessels other than the one that's being intervened upon. The Medicare has an ever convoluted and expanding, it hasn't really expanded lately, but they have a pretty strict guideline saying which vessels can be intervened upon, which physicians can do these interventions, what facilities can do these interventions. And just to keep this program focused primarily on coding, I'll just recommend that if you're billing for carotid studies, get the latest coverage policies from Medicare and check back on them every few months, because it's anticipated that these things will continue to evolve, even though they really haven't evolved in a long time. Vertebral stenting, there's codes that are available for vertebral stenting, and what you'll see is that these codes are temporary status, so they're back in that appendix to the CPT book rather than in the mainstream of codes, the ones that are alphanumeric, 0075T and 0076T. Similar to the way that we bill for the carotid stent placement, we cannot bill for the catheterization or the diagnostic imaging in the same vessel that's being intervened upon. And the only reason there's two vessels, or two intervention codes for vertebral stenting is that the first one says this is the initial vertebral vessel that we're stenting. The second one says this is each additional vertebral vessel that we're stenting. So most complex intervention is typically going to be, we might do a right vertebral and a left vertebral stent, and in that case we would use each of these codes just one time. Another service that physicians will commonly perform, and they really want to bill for it, is the placement of a closure device. Now, there are codes that are specifically available. There's one code that's a supply code that hospitals use for tracking purposes of these closure devices that they use. It's kind of like a collagen plug, basically, that's being used to help obtain hemostasis. There's tremendous clinical advantages in that most patients are able to get up and walk around a lot quicker if we use a closure device, as opposed to just putting a pressure on the access site, or even using a sandbag to apply that pressure. There's cost associated with these closure devices. So Medicare created this C1760 code to track the supply of those closure devices. And they also created a G code, G0269, which says placement of one of these closure devices. However, these services are not going to generate any additional reimbursement for the facility or for the physician, and it's inappropriate for physicians to report the placement of these closure devices. So even though there are codes there, physicians should not be billing them on their professional claims. Hospitals should only be using these services for tracking purposes. And in some cases, if we're reporting all of the supplies that are used along with the case, showing that we're using closure devices, at some point, I believe 2 years down the road, it may increase the reimbursement that you get for these procedures on a regular basis. But bottom line is that no matter how descriptive the physician is about placing a closure device, even doing angiography of the access site to determine if we can use a closure device or to help facilitate the placement of the closure device, the imaging is not billable, and the placement of that closure device is not billable. And in that, I guess I'll close this program, which is a good note to end on. Again, my name is Jim Collins. I appreciate you investing this time to learn about peripheral vascular angiography interventions. I hope this was helpful for you, and I hope that you'll be able to view it multiple times to make sure that you fully absorb this information, and of course refer back to it anytime that you need to. Thank you very much for this opportunity. I sure appreciate it.